Hello and welcome. My name is Patricia Terrell with the American Physiological Society, also known as APS. The title of today's workshop is Method to Assess Blood Pressure Regulation in Humans and in Animal Models. This is sponsored by Dr. Phil Griffiths of AD Instruments and chaired by Nina Stachenfeld of Yale School of Medicine and Lacy Alexander with Pennsylvania State University. Before we begin, on behalf of APS, I would like to thank everyone who registered for this workshop. We had 519 pre-registrants, and we're looking forward to most of you joining us today. This morning, I would also like to thank you for your awesome support. Thank you for our sponsor, AD Instruments, all volunteers, the joint program committees, session organizers, and speakers for assisting us for organizing today's workshop. And now for a few housekeeping notes. The session will be recorded and available on demand during EB 2021 and through May 31st. Also, we want to make sure that to maintain the scientific integrity and respect towards our colleagues, your colleagues, we ask that you refrain from photo or video capture of any scientific presentations in whole or part. Recording or taking photographs of another person's presentation without their explicit permission is prohibited. At this time, all attendees, except the speakers and the chairs, are in listen-only mode. You may ask questions using the chat feature and in the Zoom window, which is located at the bottom of your screen. I'm sure we all know this by now, but at the end of each talk, the session chairs will read the questions to the speakers. You do not have to wait until the talk ends before placing your question in the chat. The session will end approximately at 11:15 because we want to allow time for our sponsor to say a few words. Your feedback will assist us, so feel free to email us if there's any questions you have regarding the sessions or the questions that may not have gotten answered. So it is now my pleasure to pass the baton to Dr. Nina Stachenfeld and Lacy Alexander, who will moderate today's workshop. Thank you very much.
Hello, everybody. Thank you so much for joining us. As Patricia just told you, the title of this session today is Methods to Assess Blood Pressure Regulation in Humans and Animal Models. And on behalf of Lacy Alexander and I just want to thank you so much for joining us. I also want to take a minute to thank all of our first responders and the many people on the front lines who've worked so hard to get us through this pandemic. Over the last year, many of us have sacrificed a great deal, ranging from those people who've helped us get through at the supermarkets, to the physicians that have been saving lives, to those of us who've sat in our laboratories and attempted to get through as best that we can. I want to make sure that we recognize those people as we continue to muddle through this very difficult time. I also want to point out for a minute that it's so exciting to see our women participants included in research and leaders in the laboratory, and to remind everybody that women have been at the forefront of the world's response to COVID-19. And this is done despite constant multitasking, inconsistent institutional support for family care and career costs. And I also want to mention how exciting it is to see in our own talk today how most of the speakers today are women, and this is a movement that's very much supported by the American Physiological Society, and we're so excited to see this. And our one male speaker, Vaughan Macefield, is and always has been an extraordinary supporter and mentor and sponsor of women throughout his career. So I just want to take a second before we get going into this to remind us how important this is, not only to APS, but to me personally. And so without further ado, I'll begin these workshop talks. And I'm not going to list them here, but because we'll introduce each one individually, but I'll start with this, with the first one, blood pressure measurement in freely moving rats by telemetry. This is the gold standard method. This is given by Noha Shawky. And she comes to us from the Department of Cell and Molecular Biology at the University of Mississippi Medical Center in Jackson, Mississippi. Dr. Shawky.
Let me share my screen. Okay. Can you all see this?
Yes.
Okay. So depending on your time zone, good morning or good afternoon or good evening, everybody. I would like to thank the organizing committee for inviting me for this talk so that I can share my experience with this gold standard method, telemetry in freely moving rats. So let's get started. So the techniques used for blood pressure measurement in experimental animals are really divided into either the indirect methods, for example, the tail cuff method, or the direct methods, and those include either the catheters or the radiotelemetry. Now let's talk about the radiotelemetry more. So basically this method is the implantation or the surgical implantation of a small biocompatible radiotelemetry transmitter, or a probe as we call it, surgically inside the animals. And as you can see here on the left side of the screen, this is how the transmitter looks like. There is the catheter part, which goes inside the artery of the rat. And there is the device body, which basically does have the battery. And then there is the suture rib, which you use when securing the device inside the body. Once you insert this surgically inside the rat, you can, it does transmit biological data that is located by the receivers, which are outside the rat, and then the receivers send the signals to the computers, and the computers, as usual, do the magic stuff and give us numbers for blood pressure. And this distal part of the catheter, which is magnified here, is really a thin-walled part, and this is a very important part in your procedure. Keep it in mind, and it does have a biocompatible gel layer in the tip. Just keep this gel layer in your mind. So I'm going to talk about it a couple of slides later. Okay. The process of measuring blood pressure by telemetry is divided into 3 steps. Before implanting the radiotelemetry transmitter, the surgical implantation of the radiotelemetry transmitter, and the actual measurements and data collection. So if we start by before implanting the radiotelemetry transmitter, before implantation of the radiotelemetry transmitters, there are a couple of steps that you need to do. If you can see on the right side of my screen, this is how a radio transmitter looks like in the real life. This is the thin-walled part. And on the tip of the thin-walled part is the gel layer that I was just mentioning. This gel layer needs to be intact, doesn't have any air bubbles. So if you happen to have an air bubble as the one that I'm having here, you need to get rid of this. And this is what we call regelling the probes. And then you need to run their offsets or calibrate them to make sure you account for this in your data. And then you sterilize them overnight in a cold sterilant solution. Now comes the surgical part, or the surgical implantation of the radiotelemetry transmitters. And people really do this by different ways. Some people do femoral artery implantation, others do carotid artery implantation, but the one that I'm going to talk to you about today is the abdominal aorta implantation of the transmitters, which is a very commonly used method, and it's the one that we have been using in our lab for the last couple of years. And since we are not really allowed to take pictures of our rats, so I'm going to use those shots from a video that is posted on YouTube free for everybody, and I can share the link with you guys. It's really very useful to watch. So you need to first give your rats a preoperative analgesic. We use carprofen 5 milligrams per kilogram sub-Q, and then anesthetize your rats with isoflurane and oxygen. Go ahead and place it on the table in this way, and shape the abdomen and swab it with betadine. Then you need to make an abdominal incision. Use your sterile gauze or Q-tip applicators to start moving the organs aside a little bit until you can visualize the entire length of the aorta. You need to be seeing the aorta from the iliac bifurcation caudally until the left renal artery and vein cranially. And for those of you guys who have not done surgeries in rodents and have not seen blood vessels before, the lighter color one or the brighter one is the is the artery, and the dark red one is the vein. So this is the aorta, and this is the vena cava. And on your right side here is the left renal vein and artery of the rat. And hopefully you can appreciate here, this is the iliac bifurcation caudally. So if you can see the iliac bifurcation and you can see the left renal artery and vein, then you are on the right spot. Now I'm gonna use this cartoon to explain more of the details of the surgery. You will need to put in place your occlusion sutures, and you need to put this in two spots. The first spot is caudal to the renal vein, and the second spot is cranial to the iliac bifurcation. So what you do is that you use your vasodilator to make a small gap between the aorta and the vena cava in this spot. And then you pass your 4O or 5O suture between the two vessels so that it lies underneath the aorta. Again, you do the same in this spot, but be extremely careful not to puncture your vena cava, because really here, part of the vena cava runs behind the aorta. Once you made those two gaps and passed your sutures, you can also go ahead and place a clamp. And the reason you use the clamp and the occlusion sutures is to partially occlude the blood flow when you are making your incision. You will need a catheter introducer, and I simply use a 23 gauge syringe needle, and I bend it to a right angle, as you can see here. Now, when I have this, I am ready. So I occlude my artery, I use the clamp and the sutures. Then I go ahead and make the incision with the needle, and I keep it in place so that it acts as a guide for my catheter. Then I hold the catheter with a catheter tweezer, and I go ahead and insert it in the aorta and advance it cranially until the entire thin-walled section of the catheter here is inside the aorta. So at this point, this is what you have. You have the thin-walled part of the catheter, which does have the sensing region inside the aorta between the levels of your renal veins cranially and the iliac bifurcation caudally. If you have this, then you are good to go. Now you need to dispense a small amount of adhesive. I use the bed bond to seal the vessel. Give it a couple of seconds to make sure that it is well sealed, and then release the blood flow and be very cautious in case it's still bleeding. And then if you don't have bleeding, go ahead and return all the organs to their place. And the device body should be positioned inside the peritoneal cavity, and the suture wrap should be included in the suturing of the abdominal wall. Once you have done this, you are ready to suture the skin. And this is the video that I mentioned earlier. I'm not gonna show it, but you can refer to it after the workshop. Now the rats are allowed for recovery. You can discontinue your anesthesia, keep them on the warm blanket until they recover from their anesthesia, and then you could administer post-surgical analgesia, monitor them to make sure that they return their normal postures and behavior, and then allow them at least 2 weeks to recover from the surgery before you start recording their blood pressure. And I would like to point out here that in the past, when we used to go for shorter time periods, at least shorter than 10 days, we used to notice a drop in blood pressure rather than a consistent blood pressure. So please be aware that you need 2 weeks at least for recovery. Now the party time, right? We are all excited. We have done the surgery, which is the hard part, and we want to start collecting our data. And I would like to point out here that when I first started doing this, I had a very naive question that I'm sure that since I did ask, then somebody here should be asking too. Well, I did put my transmitter inside the rat. How can I turn it on now, right? So the answer is really very simple. It's just you use the magnet and you approach the magnet to the body of the rat, to the abdomen, since it's an intra-abdominal catheter, and it turns on the transmitter. So this is the setting that you have right now. You have your rats. The rats do have the transmitter inside the peritoneal cavity. The device body is in the peritoneal cavity. The catheter is in the aorta. The rats had the surgery and recovered, and they are housed in their cages, freely moving. The cages are placed on receivers, and receivers do send data to the data exchange matrices, which does transfer the data to the computers, and the computers do the magic, as I mentioned earlier. So this is the setting that I worked on when I was working as a postdoctoral research fellow at the University of Mississippi Medical Center. I was honored to work with Dr. Jane Rickelhoff, who had this amazing setup for blood pressure. Every single one of those is a receiver. And those are the matrices here. So really, depending on the number of receivers that you have and the number of data exchange matrices, you can detect blood pressure signal from whatever number of rats simultaneously. Now you did the surgery and you allowed your rats to recover, you're ready to collect your data. Okay, how do I know that I did a great job? In order to answer this question, I'm going to introduce you to how the arterial pulse waveform looks like. Really, the waveform is separated into three distinct components. The systolic phase, which is here and is characterized by a rapid increase in blood pressure, followed by a rapid decline in blood pressure. And this really corresponds to the contraction or the ejection of the left ventricle and the opening of the aortic valve. This is followed by a transient but a sharp drop in blood pressure called the dicrotic notch here. And this represents the closure of the aortic valve. Then there is the diastolic phase, which is characterized by a slow decline in blood pressure. And this really represents the runoff of the blood to the peripheral circulation. So this is how the waveform looks like by the book. The question is, what happens in the real world? So in order to make sure that you did a great job, you need to make sure that your signal does show the systolic and the diastolic phases. You can see those. The dicrotic notch is really very challenging to see. I don't think you'll be able to detect it, but as long as you see the systolic and the diastolic phases in your signal, then you are good. And this is how an actual signal looks like. You should be able to magnify this. So every single waveform of those corresponds to one beat. This is the rapid increase and the rapid decrease, which correspond to the systolic phase. And then this slows down. It still declines, but at a slower rate. So this is the slow decline, which represents the diastolic phase. So we have the systolic and the diastolic, and I really call this shape like it's a mountain that does have a tail. So as long as you have this mountain with the tail for every single waveform of those, then you're good to go. The next thing that you need to double check is your pulse pressure. You need to have a pulse pressure that is between 30 and 50 millimeter mercury. This is how you can tell that your signal is okay. Now I'm talking about wild type rats because it has been reported that some kinds of manipulations affect your pulse pressure. Those are not what I'm talking about. I'm just talking about your wild type rats. They should have a pulse pressure between 30 and 50 millimeter mercury. Okay, so your surgery is good. Now you want your data. It depends on the type of software you are using. The screen will look different, definitely. But I believe the components will stay the same. For example, you have numbers here. Those are the serial numbers of the transmitters that you are using. You have the option to choose which transmitter you want to review the data from. And then you have an option to choose what kind of signal you want. We normally choose the blood pressure signal. And then you also have an option to choose the time range. And I strongly advise everybody to check on the rats daily and save the data daily. So as you can see here, I'm saving the data from January 31st until February 1. So it's just every day I go ahead and I save my data. And I also save it from 11 a.m. to 8 a.m. And I skip the first 3 hours in the morning because those are really the hours where the animal facility staff come inside the room. They may make some noise, so this may disturb my rats a little bit, so I always like to avoid those readings. And then the software saves your data in an Excel file. And as you can see here, for every single hour, 11 a.m., 12 noon, 1 p.m., 2 p.m., and so on, for every single hour, you have a reading for the systolic blood pressure, diastolic, mean arterial pressure, and heart rate. And then you can average all of those, the 21 readings from the whole day, or you can average the light cycle, or you can average the dark cycle. You can average the pulse pressure in the light cycle or the pulse pressure in the dark cycle. It really depends on what you want to how you want to present your data. So those are some examples of data that people have reported with telemetry before and we have used. And I'm sure that other users using the telemetry system have done much more than this, but those are just some examples. For example, people use it to record the mean arterial pressure, systolic and diastolic blood pressure daily. And on your right side here, as you can see, this is a paper that we published last year. We had 4 groups of rats and we measured their blood pressure for 4 consecutive days. Here we are reporting the mean arterial pressure, systolic blood pressure, and diastolic blood pressure. No manipulation here, it's just that the 4 groups were different. Another example is people measuring the baseline blood pressure and then the blood pressure response to a certain manipulation, for example, a certain treatment or a certain surgical procedure, whatever they want to do. So they record the blood pressure baseline daily, and then they go ahead and give their treatment. For example, here I gave enalapril, which is an ACE inhibitor that does drop the blood pressure. The data was negative. It did not have a different effect on the two groups, but still dropped the blood pressure, and I reported that. The third example is people who are interested in the circadian rhythm and they want to report the changes in blood pressure in the light versus the dark cycle. And as you all may know, the rats are nocturnal animals. They wake up at night, they eat at night, drink at night, do all the stuff at night, and then they sleep in the morning. So normally their blood pressure at night is higher than in the morning. And hopefully you can appreciate this from the figure here, that the values in the dark cycle are slightly higher than the values in the light cycle. And then you can do whatever manipulation you want to see the effect on both the dark and the light cycle. And last but not least, some people use the telemetry to study the baroreceptor sensitivity, which is really a relationship between the change in the blood pressure and the pulse interval, or the change in the heart rate. Since you do have a blood pressure value for every single heartbeat, then you should be able to also calculate your baroreceptor sensitivity. Okay, so why is the telemetry the gold standard method? The answer to this is really in the advantages of this method. Number one, it does allow you to measure the blood pressure without handling or restraining your animals. So there is no stress. And this is definitely unlike what happens in the tail cuff method, and also unlike what happens in the catheters, or at least some of the people using the catheters. And you may doubt this and say, well, it doesn't have restraining or handling, but it does have the big stress inducer ever, it does have the surgery. But I will tell you that the 2 weeks that you allow for recovery is really enough for the rats to recover from the stress induced by the surgery. Now, the second advantage is that it allows you to measure the blood pressure in the conscious animals, which is definitely a very big difference between measuring the conscious animals and anesthetized animals. For example, what some people do with the catheters when they anesthetize the rats and go ahead and measure with the catheter. It also allows you to continuously measure the blood pressure. As we saw, you have 21 readings for 21 hours a day, and you can also have 24 hours a day if you want to. And again, this takes us to the fourth one, where it allows you to monitor the highly dynamic nature of the blood pressure in a very comprehensive manner. And this is really because you have a blood pressure value for every single heartbeat. Now comes the disadvantages. It does require skills to place the radio transmitters inside the artery, whatever artery it is. But the good news is it is not really a mission impossible kind of surgery. It is a doable surgery with some training. So you need some training, but you should be able to get skilled in doing this. Now, the other one is that it requires expensive equipment, right? You're going to spend all your money doing this, but I believe it is worth it. The third one, which I like to point out because it has been a big story, at least in the past couple of years, which is the drift. And the drift is really the change in the offset of the radio transmitters by time. So if you have a long-term experiment, let's say a 3-month experiment, and you put your transmitter inside the rat, by the end of the experiment, you had a 10 millimeter mercury change. However, when you redo the offsets after the experiment, you find the offset changed by 10 millimeter mercury. So you don't really know if that change was experiment induced or transmitter induced. However, I think this problem is really well taken care of by the manufacturing companies right now, because we no longer have this. The transmitters are very much stable in their offsets. Okay. Those are some resources that I wanted to share with you. This is the video about the abdominal aorta again, the cannulation and the device placement. This is a very nice video for the carotid artery cannulation for those who want to insert their transmitter in the carotid artery. And those are other resources for how you choose your method for blood pressure measurement if you are doing experimental animals. And with this, I would like to thank you all, and I'm open to your questions.
Thank you. Do you want to stop screen sharing? And so there were some questions that came in during that excellent presentation. Thank you so much. The first question that came in, I think you answered it a little bit. That does have to do with the comparison between this method and the tail cuff method that we see a lot. And I think a main reason that people are interested in the tail cuff method is likely the expense. Would you say that? Are there other reasons than you just mentioned to use the tail cuff to switch to this method than rather than the tail cuff?
So people sometimes prefer the tail cuff to, number one, avoid the surgeries if they don't really have the skills or they don't want to go through the process of learning the surgery. So they want to avoid the surgery. That's why they use the tail cuff. Some of them really have the financial problem where they want the less expensive equipment. However, they have to be aware that the tail cuff does have a couple of disadvantages that are really, if you just need to be aware of them, then you can choose your method depending on what you want. The tail cuff induces stress because, number one, you handle the rats right before you put them on your restrainer and then measure their blood pressure. So you handle them. This is a stress. And then you put them on a platform that is heated to 37 degrees. Just you need to raise their core blood pressure, their core temperature, so you can dilate their tail vein and be able to detect a signal from the tail. That is also a stress. It's a thermal stress. And then you restrain them. You put them in a restrainer, a small box, to avoid them moving, because when they move, you really get artifacts and the software may stop recording. So that is another stress, a restrainer stress. So all those kinds of stress affect your reading. There is, it has been reported that people do train the rats or their animals in order to get them used to it, but however, the value is very questionable. Another main problem with the tail cuff is the timing that you do it. So normally people really do it in the morning when they go to the lab, right? And as I said, the rats wake up at night. So it's like you are waking up a human being in the middle of the night, like we are doing now to our friends from Australia. Wake them in the middle of the night and then take them, put them in a box and heat them, warm them up, to dilate their vessel, and then go ahead and measure their blood pressure. That's what we do with the tail cuff method. However, it is good in detecting the big changes in the systolic blood pressure. So if you're really expecting big changes, and big, what I mean by big is something that is more than 10 millimeter mercury, in rats at least, then you can use the tail cuff method. That's the only, according to the AHA recommendations.
Another question that just came in, and this might relate a little bit to expense, was can these probes be reused?
Yes, so I'm going to talk about the probes that I personally have used, not sure about all the other probes, but the ones that I have used have a battery life of 150 days. So if you have an experiment that lasts for 30 days and you are taking good care of your probes when you are inserting them, making sure you don't really touch their thin walled part and you regel them as appropriate, you can keep reusing them from rat to rat until you are approaching the 150 days, let's say 140 days, or to be on the safer side, 135 days, something like this.
Okay, and I think we have time for, unfortunately, we only have time for one more question. And I thought it was an interesting one. There was a question that came in, was whether there were any differences between the femoral or abdominal measurements. You mentioned that you can do this either in the abdomen or the femoral artery.
Yes, that is a very good question. I believe that the difference is really in the technique that you do and in the purpose of your experiment. So, for example, we came across time when we wanted to measure blood pressure in pregnant rats. Now, or put the telemeters in and then induce pregnancy. If you want to do this, then it is really not an option to do the abdominal aorta, because the probe will be inside the abdomen and the uterus is already there. Plus, you do decrease the blood flow to the iliac bifurcation, which is really a main supply to the uterus. So you may induce low birth weight infants or something like this. So if you want to do a pregnancy in your rat, then you will need to either do a femoral artery or do a carotid artery. That's an example. So it really depends on your purpose of the experiment. That's how you choose the way. If the signal itself looks different or the values look different, I don't think so. However, I'm not 100% sure because I've not used the alternative methods.
Okay, thank you so much. We're going to have to move on. I did want to share before we move on that David Pollack has been kind enough to share a number of websites. And I think these relate to a question that came in about the brands that, and David Pollack as well from the 80 Instruments has some brands available. And so if you're interested in where to get equipment to do these kinds of experiments, go check out the chat and take a look, and you can get that information there. So
thank you. Thank you.
Okay. Okay, so we'll move on to Dr. Alexander's talk, the use of skin microdialysis to elucidate mechanisms of blood pressure regulation in humans. Thank you, Lacy.
Great, thank you so much, Nina. And I'd like to thank the APS for sponsoring this session, and also say what a pleasure it is to be presenting with such a wonderful group of people on the panel. So today I'm going to talk about the use of skin microdialysis or intradermal microdialysis and its utilization for elucidating some mechanisms pertaining to blood pressure regulation in humans. So when we think about human skin blood flow and blood pressure regulation, I think we have to go back and look a little bit at some of the purpose, and consider that the skin is a thermoregulatory organ, such that during times of cold stress or systemic cold stress that we see a profound vasoconstriction, shunting blood to the core. And then conversely, we see during heat stress, or when we have increases in body core temperature, a tremendous increase in blood flow to the skin to serve for thermoregulatory purposes. So here in this figure, we have skin blood flow along our y-axis and time in minutes along our x-axis. And what you can see is that during a time of cold stress, we see a profound vasoconstriction, whereupon then we see a period of heat stress where we see this release of vasoconstriction, and then a threshold where then the active vasodilator system ensues. So when we think about the neural control of human skin blood flow, we have to consider both the sympathetic regulation from sympathetic adrenergic nerve fibers, as well as a sympathetic cholinergic active vasodilator system. And if we see the line, the dotted line indicated with surgical sympathectomy, we see that resting skin blood flow approximately doubles. So under normal thermoneutral conditions, skin blood flow is, we're under a chronic adrenergic vasoconstrictor tone. Additionally, the cutaneous circulation is on the efferent arm of the baroreflexes. So this is some old data, both from Larry Rowell, as well as when John Johnson worked in Larry Rowell's lab as a postdoc. And this is during a perturbation with lower body negative pressure. So as you can see, as you're unloading at -30, so unloading the cardiopulmonary baroreceptors, as well as greater lower body negative pressure at a -50, that there is a profound vasoconstriction that occurs in the skin. And when we block that, so under this condition with the figure by Rowell, you can see that under conditions where the skin blood flow is halted with iontophoresis of high concentrations of norepinephrine, that both the skin and the muscle are at that efferent arm. Conversely, if you have a whole body heating protocol, as illustrated by the figure from John Johnson's paper, that there is a profound reduction in skin blood flow during heat stress conditions with that application of lower body negative pressure. And in fact, these data from Dean Kellogg back in the 1990s suggest that that sympathetic active vasodilator system is also under baroreflex control, such that during times of lower body negative pressure, when skin blood flow is elevated and that active vasodilator system is active, that the reduction in skin blood flow is because of a release of that active vasodilator system. But today, we're here to really talk about how the cutaneous circulation and how looking at really pharmacodissecting various signaling mechanisms in the cutaneous circulation can be useful in terms of examining various mechanisms that may be dysregulated in various cohorts with altered blood pressure regulation. So I like this quote, so that if we look at microvessel dysfunction, it's really a systemic disease process. And this is what makes the skin very useful for examining mechanisms of microvessel dysfunction in humans. Because it is a systemic disease process, this happens in a similar fashion in multiple tissue beds, including the skin. And so therefore, it can be very useful as looking at various minimally invasive or non-invasive models for early identification of humans at risk for peripheral vascular dysfunction and coronary artery disease. And then we can also look at the effect of a given treatment. So over the years, there have been various methods that have been utilized in order to deliver various pharmacological agents to the cutaneous circulation to get at examining some of these underlying mechanisms. And I think you can readily appreciate from these pictures that the methods have different levels of invasiveness. So over panel A, this is an example of intradermal microdialysis, which I'm going to talk about in a lot of detail today. Panel B, this is an example of microinjections into, in this case, into the finger. And then panel C, we have iontophoresis, which is utilizing and taking advantage of different currents and charge to really drive in charged molecules into the cutaneous circulation. Now, all of these methods have different advantages and disadvantages. And one that I want to point out from this figure is that there's different neural control depending on the area of skin that you're in. So for example, in the fingers or in skin that's not hairy or acral skin, we have a high level of adrenergic control. And we don't see that active vasodilator system is at play. Whereas in the forearm circulation, where we see the intradermal microdialysis probes, we have the combination of both the active vasodilator system as well as the adrenergic vasoconstrictor system. So over the years, with various skin-specific methodologies that have been utilized and investigated, we can examine the different vasodilator effects, and a really whole body of work has gone into elucidating the mechanisms that are responsible or mediating these alterations in blood flow responses that we observe. And I think the technology has really come a long ways, as well as the ability to perfuse very low concentrations of chemical agents, of pharmacological agents into the skin to be able to get at these specific mechanisms. So today, I'm really going to talk about specifically the direct drug delivery through intradermal microdialysis, but I'm also going to talk a little bit about utilizing local heating as a method for examining ENOS-specific endothelial function and dysfunction. So this table, and this is by no means a complete table, this is just a few examples of some of the different diseases and conditions that have been examined utilizing intradermal microdialysis. So looking at different methods from the local heating responses to looking at reactive hyperemia, and then also direct delivery of the endothelium-dependent agonist acetylcholine and the endothelium-independent NO contributor sodium nitroprusside through either microdialysis or through the application with iontophoresis. And what you can see is that we observe impaired endothelium-dependent dilation in a variety of these disease conditions, and that they are mediated by various different mechanisms. And then we can also observe that these mechanisms are altered with various interventions, whether that be antihypertensive therapies or statin therapies. And I'd like to point you to a very nice resource. This is a chapter that just came out in Comprehensive Physiology in 2021, which is beautifully written and comprehensive as the name would entail. So today I'm going to be talking about intradermal microdialysis as this method for administering microconcentrations of pharmacological agents directly to the cutaneous vasculature. And we have a cartoon of the intradermal microdialysis. And what you can see is that this catheter is placed into the intradermal layers of the skin. This is accomplished through utilizing an introducer, so a small gauge needle that goes along through those intradermal layers. The catheter is then thread through the needle and the needle is removed, leaving that catheter in place. The catheters come in various molecular weight cutoffs. So this is something to keep in mind depending on the size of the molecule that you want to perfuse into that area of skin. Typically, the drug perfuses out into an area of skin about the size of a dime or so, the area of a dime, US currency dime. And various molecules can be perfused through that microdialysis catheter, diffused through passive diffusion out into the, and affect both the neural and vascular signaling mechanisms. Conversely, other molecules that are released in that area can then diffuse back into the catheter, and then various substances can be recovered out from the end of this microdialysis probe. We typically pair this with both an element to control local temperature, whether you're going to be utilizing that element to induce heating of the skin or to clamp temperature to look at reflex mechanisms mediating vasodilation and vasoconstriction. And through that local heater or local cooler, there is a laser Doppler flow meter that's also placed right over the top of that microdialysis catheter. This is what it looks like in practice. You can see here that the probes are placed on the ventral side of the forearm. The reason that we do this is that the ventral side of the forearm typically has experienced less UV exposure and also has potentially less sun damage or overall sun damage when you're trying to ask questions related to aging. So we utilize that side of the forearm. You can see in the back, there's also our microperfusion pumps that are holding the syringes that are perfusing those 4 intradermal microdialysis fibers that are placed in that person's or that participant's forearm skin. One question that typically comes up is that, we observe these various changes in the forearm, but does that also happen in different regions of the skin? So we've performed studies looking at some of these regional differences, both in nitric oxide dependent vasodilation as well as sweating mechanisms. And what I can say is that typically there's not a lot of regional variation. We do see some, a small amount of variation, but there is, the magnitude of the responses is typically very similar with just small changes in other NO-dependent mechanisms. So when I teach people and people in the lab come in to utilize and learn this technique, one point that I want to get across is that it takes a lot of practice to be able to properly do this technique in the laboratory. And people come in and they typically say, I have experience doing venipuncture and IV placement, and this shouldn't be too difficult. And they typically start off, utilizing and placing needles into the skin. And I say that this angle of this needle is completely wrong. So this is what you would typically utilize for a venipuncture. And here, this 45-degree angle would go too deep and wouldn't be in the intradermal layers where we want to place this microdialysis probe. Instead, the needle should be placed at about a 15-degree angle. You can see here that we've also marked our entry and exit points about 2 centimeters apart, so that nice 10 centimeter long probe can be completely under and in the intradermal layers of the skin. So we clean the skin utilizing a sterile technique. We then anesthetize the skin temporarily with a little bit of ice. So ice for typically about a 5-minute period of time before placing needles as introducers into the skin. We then place that needle through that about 2 centimeter area. And the depth is important. So getting into those layers, you know that you're in the right layers when the participant can feel the needle placement. If you're too deep in the subcutaneous fat layers, the participant can't feel. And honestly, with the needle transition almost feels like you're going through butter. The participant can then, what I also say is that what you want to see is the grayness of the needle and the sheen of the needle, but you don't want to see, if you're too superficial, you're going to start to see the more of the needle and more of the sheen of that needle in that layer of skin. We then place the microdialysis probe through the lumen of the needle and then test the probe utilizing an inert solution, so either Ringer solution or saline solution. And what you look for is to see small bubbles of fluid perfusing or coming up out of that membrane that you can see here portrayed as that white portion. And then you'll also see a bubble of fluid come out the end of that microdialysis probe. You then pull that needle out of the skin, leaving that microdialysis probe right in place under the surface of the skin. And here, finally, you can see that the local feeding element and that laser Doppler flow meter probe are placed right over the top of the microdialysis fiber. And again, we place up to 4 to 6 microdialysis probes at a time so that a site can serve as a positive control. We have our negative control, and then any sort of interventions or localized interventions that we're interested in. So from looking at what types of responses that we see, from a method to assess, a physiological method to assess NO-dependent dilation, we oftentimes use a local heating protocol where local temperature is increased by a standard protocol. And you see an ensuing very nice plateau that is reached that is indeed NO-dependent, because then we perfuse the NO synthase inhibitor over the top of that. And you can readily see that drop in skin blood flow that is nitric oxide mediated. In a study that was recently published by Tony Wolfe here at Penn State, in this particular study, he looked at 4 weeks of vitamin D supplementation in white and black participants, and pre-vitamin D supplementation saw an impaired NO-dependent dilation, and post-vitamin D supplementation saw a restoration of nitric oxide dependent vasodilation. We also utilize a dose response protocol to examine endothelial function via pharmacological methods. So you can see laser Doppler flux along the y-axis and time along your x-axis. And this is a typical dose response protocol. And what I would point out here is that the timing of this dose response protocol typically takes about 90 minutes. And this is after the resolution of the hyperemic response period from simply placing needles into the skin. What we observe is that we want to take our values after when we reach a nice steady plateau. So each one of these bumps here corresponds to about 15 minutes a period of time as we're perfusing acetylcholine through that microdialysis probe. And at the end, we perfuse sodium nitroprusside to obtain a maximal vasodilation for normalization purposes for the data. And I think that this is really important for a couple of different reasons. One is that with so many different microdialysis probes, we need a way to normalize the data to account for the different capillaries or the number of open capillaries under that laser Doppler flow meter. Additionally, the way that the data are analyzed are going to be dependent on the questions that are being asked. So for example, we have along the bottom, the figures, the acetylcholine dose response, and we have a straight point-to-point connection of the data versus a curve modeling of the data. And again, this all depends on the questions that are being asked. If you want to look at traditional pharmacokinetics and dynamics and look at cooperativity, so in that case, we would utilize more curve modeling of the data. Correspondingly, these are data from Megan Wenner in Nina Stackenfeld's laboratory, and I would point you to this paper published in JAP in 2011, which showed that different normalization can affect interpretation of the data. So whether you look at from a constrictor function, whether you look at normalization from changing baseline versus whether you look at, you model the data utilizing different curve parameters can affect that interpretation of the data. In practice, these are data from Jody Graney, who looked at endothelium-dependent dilation in non-traditional cardiovascular disease risk factor of major depressive disorder. And what you can observe is that you can see the control sites in open circles where a site that is perfused continuously with the synthase inhibitor L-name. We can look at the area between the curves to observe really the functional NO-dependent dilation. We can also, like I mentioned previously, curve model the data to look at the EC50s. In this case, you can see that the EC50 of the acetylcholine dose response is different, is statistically different in those with major depressive disorder, suggesting the significant impairments in NO-dependent dilation with this non-traditional cardiovascular disease risk factor. These are constrictor function data, and this time we perfuse the constrictor angiotensin II in a dose-dependent fashion, looking at vasoconstrictor function in those who have experienced a preeclamptic pregnancy. So these are women who within 1 year after giving birth from experiencing or from having preeclampsia. And I think you can readily see that those with who have had a preeclamptic pregnancy have an increase in their vasoconstrictor response to angiotensin II. We pair this oftentimes with a sampling of skin. So we utilize a skin biopsy approach to get a very small skin bit and then can perform traditional biochemical analyses to look at receptor expression. And in this case, you can see that those who have experienced a preeclamptic pregnancy have an increase in the AT1 receptor expression. So how do we do this? What are some of the pros and cons? So we use a typical punch biopsy for obtaining these small samples of skin. So this is a 3 millimeter punch biopsy. You want to get deep enough into that layer of skin where you get very nice vessels. So this is right into that intradermal layers that go just above that subcutaneous fat layer. We anesthetize the skin, in this case, with a little bit of lidocaine without norepinephrine. And the lidocaine injections need to occur in the surrounding areas and not right under where the biopsy is going to be taken. The reason for this is that oftentimes if you infiltrate that biopsy tissue with lidocaine, it can affect some of the quality of the tissue that you're going to obtain. Then we perform traditional homogenization of the tissue and various Western blots or other activity assays that we may be interested in. People oftentimes ask, okay, if you take this biopsy sample, what does the scar look like? What are participants going to be concerned about? So here you see a biopsy sample that is a couple of years after healing. This is about a year in a more lightly pigmented person. And then here is about a year in a participant who experienced some keloid scarring. So the final thing I'd like to talk about is that you can utilize intradermal microdialysis and obtain, use various sampling of dialysate, to look at the recovery of various substances, either being released into those layers and or from topical application of various analgesics. So in this study, we used menthol, and we looked at the vasodilator response that ensues with menthol at different concentrations. And then we sampled to look at the pharmacokinetics and dynamics of menthol that was actually getting into the skin. And you can see that using traditional HPLC, high sensitivity HPLC, we were able to look at corresponding vasodilation as well as menthol recovery. So with that, I will wrap up and my key points, I guess more so just say proper technique training and practice are essential with these approaches. So thank you to all of the people that made this studies possible, and I'm happy to take questions.
Thank you so much. That was absolutely fantastic. Unfortunately, we have time for one question, and I had a bunch. So if there will be time for questions at the end, so we can address those. But one question that came in was I thought particularly interesting, and it was can you use microdialysis, intradermal microdialysis, to detect inflammatory markers? And there was a question with that was, can you use this in skeletal muscle to detect noradrenaline? And the question, they're slightly different, but I think the question about skeletal muscle and the relating to what you can do in the skin might be an interesting thing to address as well.
Yeah, so you can utilize microdialysis in muscle. This approach has been used to recover different substances, including histamine, other inflammatory markers. The thing that you have to keep in mind is the molecular weight cutoff of your probe. So whether a substance is going to be produced in a high enough concentration and is going to be recoverable out of that probe. There's certainly different ways to optimize that. So whether you utilize push-pull techniques, utilize greater concentrations of, say, something like albumin that can pull substances in through the microdialysis probe. And you can do this in both skin and in muscle. In muscle, you do utilize more, you anesthetize the skin with lidocaine because it's much more painful as you're going use more of a hook-shaped needle to get it into the muscle. But in terms of recovery, again, there are various techniques to aid in recovery. And from muscle, you can also utilize different approaches to look at various indices of blood flow that are going to be different from skin, where you can utilize more direct indices of blood flow, such as laser Doppler flowmetry or laser speckle imagery.
Okay, thank you.
Okay, so next, moving on, it is my pleasure today to introduce Dr. Vaughan Macefield from the Baker Heart and Diabetes Institute. He's going to be giving a talk entitled Intraneural Recordings from Postganglionic Sympathetic Axons in Awake Humans, Single Unit Recordings, and Increasing the Utility of Multi-Unit Recordings. Dr. Macefield, you're muted.
Okay, sorry, can you hear me now?
Yes, thank you.
Great, thanks Lacy, and thank you Nina for the invitation. And I'd just like to acknowledge how important it is that we recognize women scientists here, and it's great to be, I feel very proud to have been invited to speak amongst these excellent women scientists here. It's also nice to see so many friends who have logged in today. So so here's what I'll be talking about. I know that many of you are familiar with the approaches that I'll be talking about, but many of you will not be. So the technique that I'll be talking about is known as microneurography, developed in Sweden in the mid-60s. And it allows one to tap into peripheral nerves in awake human subjects. And as you can see, it's contributed a lot of information on tactile and proprioceptive sensation, pain, sensory motor control, and of relevance to the current session, control of the sympathetic nervous system, because it allows us to tap into that activity directly. So tungsten microelectrodes, which is what we use, they're insulated right down the very tip, can be inserted into any accessible peripheral nerve, median or ulnar or radial nerves of the wrist or upper arm, perineal or tibial nerves of the knee, and that's most commonly what people would use for sympathetic nerve recordings, or even the sural or posterior tibial nerve at the ankle. And there have also been a few recordings in which microelectrodes have been inserted into cranial nerves, such as the inferior alveolar in the mouth.
Excuse me, Vaughan. I don't mean to interrupt, but we'd like for you to share your screen.
Oh my goodness, all this. So
That's okay.
Nice one. Okay, look,
Go ahead and start from the beginning.
Okay. Sorry. Share screen. I thought I was doing that, right? Okay. Okay, look, so you can see this all now? Yes? Yeah? Great, okay. Sorry, as I was saying, we can also make recordings from cranial nerves, such as the inferior alveolar or supraorbital branches of the trigeminal nerve, recently the vagus nerve. I won't be talking about that. I use the NeuroAmp X by 80 Instruments. There are other amplifiers available. I should say that I was the design consultant for this, and it's a very low noise, high gain amplifier. And as you can see here, it's suitable for human connection. Got a high signal to noise ratio. And this is the head stage, the preamplifier. Because we're using high impedance tungsten microelectrodes, they do tend to pick up a lot of electrical noise. So it's important to preamplify the signal close to the recording side. So the head stage here preamplifies the signal 100 times. This is stainless steel, and a benefit of this is that it allows us also to record sympathetic nerve activity and other peripheral nerve activity while scanning the brain. I won't talk about that today. This is how it looks. We have the head stage. This is a participant's knee. We have an active microelectrode inserted into the common perineal nerve, also known as the fibular nerve. We've just marked the course of this nerve with a marker here on the skin. We give weak electrical pulses through a surface probe, and if we're over the nerve, we get muscle twitches of the foot. We get radiating pins and needles if we're activating cutaneous axons. We have a reference microelectrode and a ground electrode. So this is a differential amplifier, and we're looking at the voltage difference between the active electrode, the high impedance microelectrode, and the indifferent or low impedance reference electrode, which is just under the skin. So here's a cross-section of a peripheral nerve composed of distinct fascicles. If we're recording from a muscle fascicle of the nerve, we can impale individual myelinated axons. This is a recording of a spontaneously active muscle spindle afferent, a stretch receptor in the muscle, and here we can see it responding to muscle stretch. We can also record from typically groups of unmyelinated axons, so C fibers, or even individual C fibers. In this case, we're recording from a single muscle vasoconstrictor neuron, and I'll come back to this. It's important to note that myelinated axons generated positive going spikes. Unmyelinated axons generate negative going spikes with this monopolar electrode arrangement we use. This fact allows us to differentiate the activity of myelinated axons from unmyelinated axons. So here we have a spontaneously active muscle spindle just firing very regularly. We can extract those spikes and we can see the regular firing rate in the top trace. But in this two for the price of one recording, as it were, we can also detect these bursts of muscle sympathetic nerve activity, which are occurring spontaneously and which have this clear cardiac rhythmicity. What we've done here is shifted the nerve signal back in time to align these sympathetic bursts with the peak of the relevant R wave to which they are temporally coupled. There is a delay because of the slow conducting C fibers that carry sympathetic outflow to the periphery. So first I'll talk about how to optimize multi-unit recordings of sympathetic nerve activity. Now, because these sympathetic axons are unmyelinated, they tend to travel within fascicles of the nerve as a group. And so most recordings are multi-unit. And it's worth pointing out that the diameter of these C fibers in humans are about a micron, whereas the myelinated axons, such as the muscle spindle that I referred to, about 10 to 12 microns in humans. So an order of magnitude difference in axonal diameter. And most laboratories are just interested in the mean voltage nerve signal or the RMS, root mean squared process nerve signal. And from that, you just simply count the number of bursts per minute, that's burst frequency, or burst incidence, bursts per 100 heartbeats, the latter being used to take into account differences in resting heart rate across individuals. Some laboratories also measure total burst activity. And this is a cumulative sum of all burst amplitudes normalized to the largest burst in a recording. It's important to recognize that absolute amplitude is largely meaningless in terms of microvolts because that is determined by the proximity of the microelectrode tip to the active axons. So if you're close, you get a large signal. If you're far away, you'll get a small signal. And but also, as I'll elaborate on, it's important to recognize that there is more in the nerve signal that can be extracted, particularly when the mean voltage signal is small. And some laboratories, of course, they record the raw nerve activity, but they won't necessarily store it because you need to sample at high frequencies, at least 10 kilohertz. It uses up a lot of computer memory, and it's easier just to store, particularly long recordings, the integrated nerve signal or the RMS process nerve signal, because you can sample that at much lower frequencies. But then, of course, you lose all that you have to extract from a raw nerve signal. So here is an example on the left of a typical multi-unit recording that we would obtain from our lab. So we've got spontaneous bursts of negative going spikes. Here's the ECG. This is the root mean square process nerve signal, and this is the integrated nerve signal. They look similar, different processes to obtain these. This is essentially a leaky integrator with a time constant of 100 milliseconds. The root mean square signal, however, is a moving average here taken over 200 milliseconds. So we get a much smoother profile and we don't have a time lag introduced, which really is of no consequence. However, on the right, we can see that if we look at the raw nerve activity, we can clearly see sympathetic spikes there and we can hear them on the loudspeaker. But because there are so few spikes contributing to the signal, you see very little in the mean voltage neurogram as shown in the top trace. So do you look at this recording and say, this is rubbish? Or do you look at this recording and say, wow, this is great, because look at these spikes I can record? Well, many would say, no, we can't use this. That's a waste, in my opinion. So this is a typical oligo-unitary recording, oligo meaning few. So we've got a few sympathetic axons firing spontaneously. We've got some large spikes, we've got some small spikes here. And clearly, when we've got a few neurons active, few axons active, we get a nice population response for the RMS nerve shown here. This simply shows, the asterisk shows that there's an ectopic beat, and then we get a prolonged cardiac interval here and a compensatory increase in muscle-sympathetic nerve activity. This fall in blood pressure shown here. It is important to recognize artifacts in a nerve recording, and unless you have the raw nerve signal on hand, you may not be able to recognize it. This is blown up here. This individual electrical artifact, very brief spike, generates in the RMS, beg your pardon, a characteristic square wave profile, which is clearly different from the smooth ramp, up and down ramp that we see with a sympathetic burst. We can use, so look, I use 80 Instruments software, lab chart. There are other approaches people have used, but within the feature called cyclic measurements, which looks for regularly occurring peaks, you can use this to detect from the RMS nerve, or the integrated nerve, bursts of muscle sympathetic nerve activity on the left, and they're shown, the detected burst is shown here, and also from skin sympathetic nerve activity on the right. A skin sympathetic nerve activity, which is relevant to what Lacy was talking about, the bursts are much broader than the bursts of muscle sympathetic nerve activity shown on the left. And this shows what I mean with the cyclic measurements. There are various presets. So if you want to look at heart rate and you're obviously using the ECG, there's a preset for ECG, for rat, for dog, for humans. For the sympathetic nerve recordings, there isn't a preset for that, but here's a nice little tip. Use respiratory airflow, because respiratory airflow is characterized by slow ramping up and down profiles, and it actually works very, very well at detecting bursts of sympathetic outflow, both to muscle and skin, in the multi-unit RMS or integrated nerve signal. We can adjust the threshold here. This is currently set at 1.5 standard deviations. We can adjust that threshold, so we're just detecting these big bursts and not the noise in the background. And this is shown here. So here's a screenshot of a recording from our lab, spontaneous bursts, negative going spikes, and this feature, the cyclic measurements, has detected these bursts. And then we can set up another channel shown in green, where instead of just presenting event markers for each burst, we can get a cumulative count. We can do the same for R waves. We can count the R waves, we can count the peak inspiration, etc. So it's a very, very useful feature. We also use another feature called peak parameters, which allows us to select an individual burst, measure the rise time, the width, the peak amplitude, baseline, area, etc. We also use this approach to get the individual burst amplitudes with every R wave. So we just simply write a macro. So we've now shifted the nerve signal back in time to align each burst with the peak of the R wave. And then we simply jump from R wave to R wave and measure the burst amplitudes. So we get low amplitudes for zero bursts and high amplitudes for actual bursts. And then it's just a matter of exporting the data into Excel and saying, okay, anything above 0.2 microvolts we call a burst or something. And the spike histogram feature of LabChart, and of course other data acquisition and analysis processes have similar features. It's simply a window discriminator, which allows one to extract these negative going spikes from the nerve signal. So here's the RMS nerve signal, here are the negative going spikes, and the spike histogram software has plotted in this row down here called spikes, all these bursts that we've set the threshold to detect. We've also used this same software to detect the R waves of the ECG and also the inspiratory peaks of the respiratory signal. So now we have these timing events of in this case, muscle sympathetic nerve activity, the R waves of the ECG, the inspiratory peaks of the respiration, and we can generate autocorrelation and cross-correlation histograms. Also a feature within spike histogram. If we look at the left, on the bottom is the autocorrelation histogram of respiration. So time 0 is the first inspiratory peak, here's the next inspiratory peak, the one after, and then back in time over here. And this is the cross-correlation on the top, which basically is showing the timing of each sympathetic spike with respect to peak of inspiration. So you can clearly see that there is respiratory modulation. We know that, but this allows us to quantify it. On the right, we see the very well-known cardiac modulation of muscle sympathetic nerve activity, the autocorrelation, the ECG shown on the bottom. This is muscle sympathetic nerve activity. We can use the same approach for skin sympathetic nerve activity. And although most people say there is no relationship between skin sympathetic nerve activity and blood pressure parameters, it still has cardiac rhythmicity. And this allows us to detect it. It also has, we know that it is modulated by respiration as well. And if we compare muscle and skin sympathetic nerve activity, well, really the standout feature is that the cardiac modulation of muscle sympathetic nerve activity is much greater through the strong coupling with the arterial barrier reflex. The cardiac modulation of skin sympathetic nerve activity is of a similar magnitude to the respiratory modulation of skin sympathetic nerve activity and the respiratory modulation of muscle sympathetic nerve activity. So again, we can quantify these. We can look at respiratory sympathetic coupling in health and disease, which I won't talk about. But we can also use it to look at this approach to look at other cyclic inputs. In this case, we're applying galvanic vestibular stimulation behind the ears, which induces sensations of swaying side to side, can induce nausea. It's a way of activating the vestibular system, and we can clearly see that we've got cyclic modulation of muscle sympathetic nerve activity, frequency dependent. So again, we can quantify that. The reason I'm showing you this is this analysis is based on the extracted sympathetic spikes, not from the RMS process signal. Importantly, by extracting the sympathetic spikes, we can, using spike histogram, we can separate out the sympathetic activity from myelinated axons, like the muscle spindle I showed you, or importantly, EMG. So here, the participant has just tensed the leg. That causes a shift in the baseline of the mean voltage signal, which means it can be hard to detect these bursts of sympathetic activity. But we all know that neural spikes have a very brief duration, half a millisecond, say, shown in this cluster here. EMG spikes are much broader, and we can separate those. Then, having extracted these negative going spikes, we can generate the spikes down here, and we can reconstruct the mean voltage neurogram from these extracted spikes. Importantly, this approach allows us to record sympathetic nerve activity to contracting muscle, which people have had difficulties with before because of the EMG infiltration of the nerve signal. But by extracting the sympathetic spikes, we can measure sympathetic outflow to contracting muscle, and we can, and basically the approach shown here, we do R-wave triggered histograms. We quantify the number of spikes within the burst of EMG of sympathetic nerve activity. So we count the spikes, and we can look at how that changes in a given maneuver. But importantly, we can record in terms of spikes per minute the increases in muscle sympathetic nerve activity to a contracting muscle, even up to 50% of maximal voluntary contraction. And here's the blood pressure increase during isometric contractions. And we can clearly see that there is an increase in sympathetic outflow to the contracting muscle. We've also used the cyclic spike histogram feature to look at rhythmic exercise. Here we're just doing slow isotonic dorsiflexions of the ankle. We're recording these bursts of sympathetic nerve activity, extracting the sympathetic spikes, performing cross-correlation histograms. This is the muscle sympathetic nerve activity versus the EMG, and this is the cross-correlation of the EMG versus movement. Clearly, we've got entrainment of sympathetic outflow to the EMG, which is obviously entrained to the voluntary movement. This modulation of sympathetic outflow is much higher to the ipsilateral muscle, that is the contracting muscle, than it is to the non-contracting, to the contralateral muscle. And we can quantify that as shown here. So the EMG modulation is the same on both sides, of course, but the modulation index, how sympathetic outflow is modulated during the voluntary contraction, is much greater to the ipsilateral muscle, contracting muscle. So just to summarize this first part, although overall burst properties continue to provide useful information, there's actually much more than these somewhat gross metrics, burst frequency, burst incidence, for instance. Extracting the negative going spikes allows us to get rid of artifacts and perform cross-correlation analysis. And then that leads us to some pinnacle, as it were, of extracting sympathetic activity from the raw nerve signal, and that is recording from individual sympathetic neurons. Now, the approach is exactly the same, but we use much higher impedance microelectrodes. And what you really want to get is a recording in which the spikes stand out from the background noise. Here we have 2 spikes labeled 1, and down here we've got these same 2 spikes labeled 1, and these smaller spikes labeled 2. Now, with any single unit recording, whether it be in humans or experimental animals, the principle of spike superimposition is used to confirm beyond reasonable doubt that you are recording from one and only one axon. Here we have individual spike morphologies from this labeled neuron here, and if we superimpose them in E, we can see the uniform spike morphology. Conversely, in D, we've got these smaller spikes, and they have varying shapes and sizes. So this is not a single unit recording. This, on the other hand, is a single unit recording. And on the right, I've shown a figure from Michael Gilby in London, who records from individual sympathetic axons supplying the rat-tailed artery. So it's clear to see that the spike morphologies are similar to what we record in humans. Triphasic profile with a negative, a dominant negative peak. We can look at, this is now a human recording, we can look at physiological increases in sympathetic outflow. This is during a maximum inspiratory breath hold, which causes a sustained increase in sympathetic outflow, shown in the RMS process signal. Importantly, individual neurons, shown superimposed here, they just putter away, firing mostly once per burst. This is a common feature. And in fact, we see it for muscle vasoconstrictor neurons, cutaneous vasoconstrictor neurons, and pseudomotor neurons. What this shows here is the number of times that a given neuron does not fire, so 0 spikes, fires once, twice, 3 times, or 4 times within a cardiac interval. And you can see that the muscle vasoconstrictor neurons, they're mostly silent. About 70% of the time at rest, they're silent. Firing probability, when they are firing, about 31%. Similar patterns that we are seeing with cutaneous vasoconstrictor neurons. These were recorded during exposure to cold, just before they were shivering. I returned to Sweden to get these recordings. We couldn't get subjects cold enough in Sydney, probably be easier in Melbourne. And in pseudomotor neurons, we heated the participants. Again, similar patterns. And in the bottom trace, if we simply look at those cardiac intervals in which the neurons were firing, we can see, regardless of their identity as muscle vasoconstrictor, cutaneous vasoconstrictor, or pseudomotor neurons, they're mostly just firing once per burst. They occasionally fire twice, 3 times, 4 times. Here is in a patient with heart failure, and we've got these ectopic beats with prolonged cardiac intervals. As I mentioned earlier, that induces a compensatory, larger and broader burst of sympathetic nerve activity. In this case, this neuron, despite being recorded from a patient with heart failure, with very high sympathetic outflow, it's just puttering away 1 spike per burst. Here, during the ectopic beats, is firing twice. Again, I won't go through all this, but
2 minutes.
Sorry?
You have about 2 minutes.
Yeah, cool. I won't go through this, but if we can look at different disease states, and we can see how the firing patterns can change in different disease states, but on the whole, individual neurons fire once and only once. So to summarize this part, as I just said, they primarily fire only once per burst, irrespective of their identity. This is also seen in physiological and pathophysiological increases, and the firing rates increase from about 0.4 hertz to 1 hertz. So again, very, very low firing rates in human postganglionic sympathetic axons. And this indicates that increases in firing probability and the recruitment of silent neurons and not rate coding is the primary means by which increases in sympathetic drive are brought about. Now, there's another approach. Kevin Shoemaker and colleagues popularized this wavelet decomposition of multi-unit sympathetic recordings. You can extract individual units and look at their recruitment properties. This is great, but it can't determine the firing rates, and for that you need single unit recordings. And recent studies by Philip Miller and colleagues have shown that not all vasoconstrictor neurons, muscle vasoconstrictor neurons, receive the excitatory drive. Some are inhibited during certain maneuvers, and this is an exciting new area. Final conclusions. I won't go through this in detail, just to show them here. This is more to the nerve signal. We can extract individual spikes. We can get rid of interference from myelinated axons or EMG. We can perform cross-correlation analysis. And of course, we can record from single axons. Thank you very much for your attention. And look, just feel free to contact me. There is a recent review I wrote. It's freely available from clinical autonomic research, and this covers a lot of the things I was just speaking about. Thank you.
Thank you so much. We have several questions in the chat, and I think we have time for probably one. And I'm gonna, this is from, says, can you discuss the significance of multi-unit versus single unit recordings in pathophysiology, such as studying the study of MSNA in lean and obese hypertensives?
Yeah, look, that's a good question. And my colleague Elizabeth Lambert, who's at the Baker Institute, has done a lot of work on that, shown that so by recording from single units, you actually get more information, and has shown that there is an increase in single unit multiple firing in individuals with obese hypertension. So there are differences between obesity per se and those obese individuals with hypertension. So you can, the single unit recordings do give a finer level of information that multi-unit recordings provide. Having said that, I'm not disputing the utility of multi-unit recordings. We need both sorts of information. But importantly, it can differentiate between pathophysiology and normal physiology. Some people have high levels of muscle-sympathetic nerve activity at rest, similar to people with heart failure, but their single unit firing properties are not changed. So that tells you that they're normal.
That's fine. Thank you so much. As I said, there are more questions in the chat, but we'll save those until the end. There's also Patrick Mueller there's a session on Wednesday specifically about pathophysiology and looking at analysis of sympathetic nerve activity. So look at that in the ED schedule. And with that, I'll hand it over to Nina.
Thank you very much, and thank you for a wonderful talk, Vaughan. Fascinating. I always learn an enormous amount when I hear your talks.
Excellent, thank you, and thank you all so much for all of your wonderful presentations. So we now have some time just for a few questions to the various presenters today. And I'm going to start off from one to Dr. Macefield. And this is from Justin Sprick, and he asks, is there any utility in applying single unit nerve recordings in the study of neurovascular transduction, i.e. the change in mean arterial pressure or blood flow in response to a given burst of MSNA?
Thanks, Lacy. Yeah, look, it was a good question, and I responded directly to Justin, but basically, I don't think it would be particularly useful given that the vasoconstriction is brought about by the activity of many sympathetic axons. Look, it'd be interesting to look at that with, in the skin with microvasculature, but with large systemic vessels, I don't think there'd be much advantage to trying to correlate vascular transduction to the firing of single axons. Not saying that it can't be done, and perhaps it should be done, but yeah, my first thought would be it wouldn't be particularly useful. But good question.
Well, Nina, you mentioned you had some questions for Lindsay.
No, I got to those were my questions, and I got to.
Excellent. Well, with that, there's been a lot in the chat box and answering directly back and forth to one another. I want to thank all of the speakers and